let's get started. And I'm sorry for the delay and the technical glitch that we are facing. But we come to our second webinar. We have two very distinguished moderators for this session. Let me introduce you to them, and then I will hand over to. So we have Dr. Ian Jackson. He's an anesthesiologist. He is from the UK and the past president of BADS and past president of the IAAS. And we have Dr. David Bunting, who is a surgeon, and he is also a past president of the British Association of Day Surgery, and he is the General Assembly member representing UK in the IAAS. So over to you, Ian and David, and I will, whenever you let me, I'll start my presentation.
Okay. Will I go first, David, or do you want to go first?
I don't mind if you're happy.
So this is first presentation will be from two views to one vision, uniting clinical and operational goals in ambulatory surgery. It's a really interesting talk by Fabricio Galvao from Brazil.
Hello, everyone. It's a pleasure to be here with you. Thank you very much for the invitation, and it's a pleasure to see you all again. Thank you for the hosts and the people that are watching us right now. Welcome. And I'm here today to talk with you about the lecture that we gave in the last International Congress of Ambulatory Surgery in the beautiful city of Dubrovnik last May. So the topic of this conversation today will be from two views to one vision. And I'm very glad to be here. And thank you all once again for joining us today. So from two views to one vision, we are going to talk today about how we can unite clinical and operational goals in ambulatory surgery. My name is Fabricio Galvao. I'm a member of the management body of IAAS. I'm the founder and ex-president of Sobricam, the Brazilian Society for Ambulatory Surgery. And I'm very glad once again to be here with you today. We have those two guys facing each other. We have the surgeon on one side. We have the manager on the other side. We have the patient in the middle. And those guys are working in the same place. And sometimes they think they are working in the same direction, but one have different things in mind. The care team sees the patient, sees the outcome, thinks about safety, thinks about autonomy. On the other hand, the managers, they think about the quantity of cases they are performing at the center. They see how much of the utilization is being occupied, and they think about numbers, margin, sustainability, and profit. So those both views are not wrong. They are correct, but they are incomplete. The thing is that they are misaligned, and when we have misalignment, we have visible and invisible costs. So we have three examples here. One talking about the mandate and the surgeon walkout when they have a mandate for a 12-minute turnover of the operation room without surgeon input, without knowing how this will affect the operations by the view of the clinical and care team. The result was that in 8 months, 6 of the 11 surgeons was gone, and the volume of the center went down 40%, and they had to close doors and was sold at a loss. The second example is about a supply swap when they decided on the management side that they could save a lot of money by switching one antiseptic solution. The saving was very nice, about 80,000 euros, but they had a very important rise in the infection rate, and the settlements of lawsuits was 4.1 million euros. So that was a huge mistake with misalignment. On the other center, they had a dashboard that killed the trust. They put a real-time efficiency rank in public, but they were not taking into account the complex surgeries and how those complex surgeries will be lower ranked because they were not balancing those stuff. So all the surgeons stopped to accept the complex cases to get better rankings, and the revenue collapsed. So in the first example, we have how efficiency without alignment is not efficiency, is a debt. On the second example, we have the cost decisions made without alignment are not savings, they are hidden expenses. On the third case, we have that what you measure publicly without alignment is what you eventually could destroy and expose. So we have three centers, three different continents, and one root cause that was misalignment. So the pivot here can come by understanding what is value and the equation of value that was placed in a book by Michael Porter in 2006, and it's very updated until now, because he states that value equals outcome divided by cost. So when we think about only outcomes, we are not necessarily thinking about costs, and when we think only about cost, we are not necessarily seeing the outcome. So both things together equals value. So we'll keep that in mind, because that's an important concept to have when we think about alignment. So the quality and efficiency are not the enemies. The enemy is the waste. So when we think about what we can lose by having misaligning decisions, as we explained in the last slide, we can have a lot of waste, a lot of costs, and a lot of things that are being done without the maximum quality and efficiency when both sides are aligned. Taking this to the other side, we spoke about misalignment. Now we will talk about how alignment works and how this one vision looks like, with three other examples from different centers. This one is from Seattle, an example of co-leading the work and how they performed a leadership pact with a Toyota production style system adopted by the surgeons in the room, and the length of stay was reduced, the malpractice premiums dropped sharply, and the managers, the surgeons, the nurses, the technicians, and everyone was knowing where to go and talking about the same direction and sharing the same stories. On the second center in Toronto, Canada, we had a single procedure centers that was hyper specialized in hernia repair. They had a 99% success rate, and they had costs half of the average of the industry there, by one defined business model and alignment between everyone working at that center. On the third case, we have a similar case of sharing a dashboard and a scorecard, but this time with alignment. And this shared scorecard was from a single disease prostate center in Hamburg, Germany, where the surgeons, nurses, and administrators share one public outcome dashboard. So this turned out to be something very important for them, because everyone was thinking about the same numbers and going to the same direction, and cheering together for the best results and the numbers when every time they got improved. So in the first case, we have the chief medical officer and the chief operational officer co-presented every change, so they are aligned and they have the leadership and the influence between their teams, the care team and the management team. On the second example, we have the clinical engine as the business engine. So things started with the surgeons, with the hyper-specialized center, and how that could be worked on the most effective way to get the better possible outcome with 99% success rate and half of the cost of the industry. And on the third case, we have a radical transparency from the first example, with the misalignment replaced by internal politics and everyone sharing the same goals and working together to achieve those goals. So we have here another 3 centers, another 3 countries, and 1 vision shared. And this +1 is that it's because I placed 1 personal story. And this is a case from Brazil, that is from my center, where I'm a founder and executive director. And we had a program there at Hospital Excellence called Cuidado Máximo Desperdício Zero, that stands for Maximum Care and Zero Waste. We had a challenge there that with rising costs of consumables, with a high variability in supply use and a margin pressure, those things were pressuring the expansion plans and the reinvestments in the structure and in people in the structure. So we placed a standardization process, co-designed it with surgeons. We had an education and training for the care team and also the suppliers. We have an alignment on the same numbers, same goals every month. And the results was that the supply cost utilization, the supply utilization was reduced by 20%. The supply costs was reduced by 12% with increasing purchase margins, and the savings were reinvested in new equipment and new resources for the unit. That's the team responsible for this program, part of the care team, part of the management team, together in the hospital. So this is a live and personal example of how we can put everyone together in the same room with the same stories and sharing the same numbers to achieve better goals. And we propose a framework here to work with the alignment theory, to be on the same room, to be talking about the same numbers and sharing the same stories. So by doing that, we can have this alignment approach together and everyone working on the same direction. That is very important. So once again, if you remember something from today, remember same room, same numbers, and same stories. That can make a huge difference in the outcomes for everyone when they are on the same page, going to the same direction, and knowing what are the goals and the challenges from each side of the table, care team and managers. So from now on, with no exception, know your counterpart, have a conversation, understand what they are thinking, what they are doing to make his work better, and how you can join this to make it better too. The second thing is to pick one metric that you both own, you both know, and you both can work together to address. And the last one, tell the next story together. Put everyone in the same table, share the story across the care team, across the management team, understand each other, and tell it together. So people will get more engaged, will gain more trust, and will be more willing to participate in whatever you want to put together in your unit. So this is something very important to have in mind. Don't try to fix the whole system. Try to fix the alignment. Going to the end here, I would like to say that from 2 views, 1 vision, we have 1 vision, and from 1 vision, every patient wins. Thank you very much. It was a pleasure to be here with you again. Thank you for your time. I'll be happy to answer questions and also to be connected with you on LinkedIn. You can use the QR code or search for my name on LinkedIn and we'll be connected. And I would like to share also this incredible book that was published recently by the IAAS team and the editor, Girit Joshi. And we are very proud of this work. Many of the IAAS members were contributing from almost every continent. So scan the QR code and have access to this recent important publication in ambulatory surgery. Thank you very much. Bye-bye.
For now, I have Erik's presentation here with me ready. I can share that. and then I will try and.
We could
Erik?
do that. Yeah, if Eric's ready,
Yeah,
we could.
Yeah, I'm ready to go.
Okay.
If you
I'll
like.
make a quick introduction. Welcome, Erik. This is Erik Lithonius. He's a PhD. He's a leading Finnish medical professional based in Helsinki. The chief in the trauma anesthesia and deputy chief physician at the Department of Anesthesiology. His medical and health research spans a lot of trauma, anesthesia, critical care, and particularly ambulatory surgery. He's regularly involved in a lot of international educational events such as this, and I'm delighted to hear from him today. He's going to talk to us about building a resilient ambulatory centre. Thank you, Erik.
Thanks, and thank you for inviting me to this webinar to speak. So I'm just going to start with a case we had this May in Helsinki. At about 4 in the morning, there was the first ever public emergency warning concerning suspected drone activity in the Helsinki airspace. And over 1 million residents were told to shelter indoors and stay away from windows. The capital's airport was closed for hours. And the all clear, fortunately, came a little past 7. But this caused a lot of confusion at our hospitals in the university hospital system. This was completely surprising. There was no clear guidance from senior management as it was very early in the morning. And staff didn't really know whether they should disobey the instructions from the authorities and just come into work as normal, or whether they should stay home and stay in place as ordered. Now our own department, the trauma surgery department, everyone just spontaneously came in as normal. But again, at one of our more peripheral hospitals where they do a lot of day surgery, a fellow chief told her staff to shelter in place, and they lost some hours of the morning because everyone came in late. But this sort of illustrates that surprising things happen, and it's up to organizational resilience to just manage through even the most surprising situations. Now, please go to slide number 2. Let me just make sure we're seeing that. Yes. So every ASC, every single day, decisions have to be made under uncertainty, and you can't write instructions for everything. So people have to make decisions on their own, of course, with the best knowledge. You really have to work at this, because if you look at recently published study from JAMA Surgery that looked at more than 2,000 ambulatory surgery centers in the States, showed that if you had a procedure at a center for which that procedure was low volume, that is less than 50 cases of that procedure during a year, you had worse outcomes, especially if you were sicker, especially if you were sicker and an orthopedic patient. So this means that routine and having a good protocol for things that you do is important. It also illustrates how, when ambulatory surgery started out, most patients were fit, and the selection criteria to have ambulatory surgery were quite strict, so we didn't get the sicker patients. But now, because of production pressures, just generally the population getting sicker, and also, of course, ambulatory surgery becoming much better at handling difficult cases, we have a completely different set of patients we take care of now, and we need to be ready for this. Next slide, please. One of the main researchers studying this is Erik Holnagel, who's worked on resilient healthcare, and defines resilience as an organization's standing capacity to do 4 things. That is to anticipate what might come next, to monitor what is happening now, and to respond when something deviates. And then lastly, to learn from both successes and failures. Now, hopefully every ambulatory center is already well prepared to respond. That's why we have protocols, we have drills, we have checklists. But we might not be that well set up to anticipate and to watch every team's workload in real time, or to learn from the days when everything went right. Now, next slide, please. I'm looking at this through 3 connected pillars. So we have selection, which serves anticipation, simulation serves response and monitoring, and the 3rd pillar, everyday resilience, serves learning and feeds back into anticipation. You take any of them out and the structure collapses. The next slide, please. So we'll start with the selection pillar, which should be a living process. It's not something you just decide when you open the center that these are the cases we're going to do. You have to keep moving. You have to monitor whether you're still doing the correct cases at your center. The more you prepare, the more rarely you actually need your crash cart. And the first thing you do is select the patient that you're able to treat. Next slide, please. Now, I'd like to pull up some finished data because I think we've come pretty far, and it's a system that I know best. Of course, the principles transfer, even though, of course, some of the protocols we have nationally are not the same everywhere. About 10 years ago, there was a study on unplanned overnight admissions, which showed that we had a rate of about 6% over 14 units in about 6,000 cases. Interestingly, there were more unplanned admissions in centers where day surgery shared the space with a lot of inpatient work, and fewer unplanned admissions from units that were dedicated to day surgery. And this still holds in the recently published POPPY study, which looked at 200 sites and found that roughly about 1 in 8 planned day case patients were not discharged on the same day. And there were some surgeries where more than half of the patients stayed overnight. So this suggests that a good starting place, if you want to look at resilience and want to look at your patient selection, is to study, to pull up your own unplanned admission rates and select by procedure. And if you see some procedure standing out, then maybe that's a good conversation to have about whether these patients are appropriately handled at your center, or whether they should be done inpatient, or if there's something you could do to select the patients that are having day surgery. Next slide, please. And then, of course, you also have individual guidelines, and I think obstructive sleep apnea is one of those chronic issues that are studied in ambulatory surgery. And the Finnish Society of Anesthesiologists recently published a recommendation making screening for obstructive sleep apnea explicit, and recommend the stop bang questionnaire, which is a very easy 8-item screen. And if you score higher than 5, that triggers consideration for either overnight stay or at least following you longer in the recovery room, and documenting how the risk of apnea is taken care of. And as you can see from the slide from Chung's article in the British Journal of Anesthesia, the risk of issues rises with rising stop bang score. And so the cutoff that the Finnish Society selected was 5, just from where there's a 50% probability of the patient having moderate to severe sleep apnea, which then would cause risks for severe issues after surgery. Let's go to the next slide. And then, of course, selection also helps you take on larger procedures, and of course also expanding to a 23-hour surgery model has enabled Kuopio University Hospital to perform almost half of their elective surgery as either same date or next morning discharges, which I consider quite impressive considering that a tertiary center does some very heavy surgery. And they, of course, do this by good patient selection and booking the right cases the right way. Let's go to the next slide. But of course, even the best selection will not catch every unexpected event. So the next thing is being prepared for when something goes wrong. And that's where simulation comes in. In situ simulation is the best way to prepare. So you actually simulate in your center. You don't go to a separate simulation center, which means that you can check that equipment is where it should be, that the protocols are up to date, and the people know where things are. Next slide, please. As a part of preparedness is, of course, crisis checklists and cognitive aids, and the evidence for these is unusually clean. There's a classic trial published in the New England Journal of Medicine in 2013 that had 17 operating room teams managing simulated crises, and they were randomized to do this with or without crisis checklists. And following what happened, without the checklists, 23% of life-saving steps were missed, and with them, just 6%, which is a nearly 3/4 relative risk reduction. There are almost no other patient safety interventions that show an effect that is that large. And asking the clinicians, about 97% of them said that they would want the team that took care of them to have a checklist if they were the patient. Next slide, please. And another issue is the question of dantrolene for the treatment of malignant hypothermia, which is, of course, so rare that most anesthesiologists might go through their entire career without seeing a case that is a reaction to inhaled anesthetic gases or to depolarizing muscle relaxants like succinylcholine. In the past, it was fatal in most cases before the discovery of dantrolene, and it is survivable when dantrolene is given fast enough. And fast enough means that you need to have the dantrolene ready in your center. The European Malignant Hypothermia Group recommends that it should be available anywhere where triggering agents are used, with the first dose ready to go in 5 minutes. And you need 36 vials of this. But if you're further away from the next center that have these or a larger stock, you need 60 vials, which unfortunately carries some cost. I believe at least in Finland, it's one set of dantrolene is a few thousand euros, and the vials go bad in a few years. The Malignant Hypothermia Association in the United States makes the same recommendation. But the uncomfortable part is that this is something due to the cost and the rarity of the event. Many centers skip this. There was a nationwide survey in Sweden in 2024 that found that only about half of public hospitals and just 1 of 9 private institutions actually stocked what was recommended. And thinking, if you remember that you have to have the dantrolene ready to go right away within 5 minutes, if you think that sharing a stock with the center 15 minutes away is enough, then you don't have dantrolene at your center. And the same, of course, goes for anything you need very quickly: epinephrine, airway equipment, and so on. Wall posters are only useful if the team knows where to look for them, and so on. Next slide, please. Crisis resource management came to medicine from aviation where it has been a teachable skill since late 1970s after some very major accidents. Some colleagues at Stanford adapted it to anesthesia, and the principles are simple. You have clear roles, you communicate through using a closed loop, an order is given, whoever is the target of the order repeats it back, it's carried out, and you confirm that you've carried out the order. You communicate to share what's going on, you anticipate, and you call for help early. But you need to practice this. This is something I'm sure everyone has done at some point, and hopefully still does at least yearly. At the trauma center, we drill every other week for the most emergent cases. Every year, we almost quarterly, we run bigger drills on mass casualty events. And every time we do these drills, it surfaces something new, something, equipment that's not where it's supposed to be, a protocol that's not been updated, someone that doesn't know where they're supposed to be at a certain point. And they're not failures in training. That's sort of part of the intent of running these drills is finding where the problems are so we can correct them. I believe ambulatory surgery centers, even though the acuity is lower and hopefully emergencies are rare, need to prepare in the same way. Because when something happens, you have to know what to do. Next slide, please. So the next pillar is learning and everyday resilience, learning from what goes right. Next slide. So the traditional way of thinking about learning is to look at incidents, you investigate when things go wrong, and you try to figure out how to avoid things going wrong the same way. But that sort of has you waiting for something to go wrong. Erik Holnagel, in his work, argued for studying the other half, which is sort of looking at days when everything goes right. You should also put some emphasis on what you did to make things go so well, and learn from that, because that will actually have your site running a lot better all the time. The next slide, please. So where do we start? And I think one of the most important things is to make sure we run a center in which everyone feels psychologically safe. So traditionally, medicine has been quite hierarchical, and some of the most tragic incidents have occurred due to someone sort of lower in the hierarchy not feeling able to speak up when the seniors are missing what's going on. Just following what's happening, either in a drill or just in a regular day in an operating room, and seeing whether a nurse or a surgical tech is able to speak up without the surgeon or the anesthesiologist stepping on them, gives you an idea of whether everyone feels psychologically safe. And second, spend a little time at the end of the day with the team thinking about what went well. Was the team able to anticipate something that was a little off, something that was unprepared for, and how were you able to push through or manage to avoid the complication? What made turnovers fast, and so on. And third, audit your capacities. You can start your mornings with a morning huddle and look at the lists, make sure everyone is knows what's going to happen that day. Monitor the team's workload. Make sure everyone's not worked to the bone every day. And when something happens, hand out clear roles and ask for help. And keep learning from successes and the rare disasters. Next slide, please.
You are done.
I'm done. Yes.
Yeah.
I'm done.
Yes. So that was the last slide, the references.
That was all. Okay. Yes. Very good. So just a few last words. So just selection, simulation, everyday resilience. Remember, anticipate, monitor, respond, and learn. Thank you.
Thank you, Erik. Fantastic insights there, especially into the safety aspects, the human factors, and really the power of outcomes and looking at our data and how these dedicated surgical centres with a sort of defined goal can help, you know, with a critical volume can help improve our outcomes. So thank you very much for those really useful insights, Erik. Naresh, do we have a presentation that you can share for Fernando?
Yes.
Ah, fantastic. We can see that.
Well, good afternoon.
Welcome, Fernando. Fernando is a prominent Spanish surgeon and expert in ambulatory surgery. He has authored the Spanish Association of Surgeons Consensus on Ambulatory Surgery, and he has a huge amount of experience lecturing worldwide, both on ambulatory surgery, but also lots on surgical training and minimally invasive techniques. So I'm really excited to hear from Fernando this afternoon. He's going to talk to us about teaching and training competencies, specifically with regard to ambulatory surgery. Thank you, Fernando.
Thank you. Thank you very much. Good thing. Next slide, please. Yes, my experience is about 30 years ago in the General Hospital of Virgen del Rocío from Seville, and we have no conflict of interest. And this experience is about because I was in this time the director of the United Day Surgery Unit and professor of the Faculty of Civil and tutor of surgical residents in that period. Next, please. Next slide. As said Paul Jarrett years ago, these units must be the best place to develop so anesthetic and surgical procedures in this day and the future. Next slide, please. In that way, we have to develop a competence base for teaching and training in modern surgery. Next, please. Yes. You know that in modern surgery really happens outside 85% maybe outside of the hospital. In that way, in surgical education may be adapted to shorter hospital stays and out of hospital medicine. Next, please. In our hospital, we have a percentage over 50% of outpatient surgery. It's a very great hospital of Spain, and we have in the teaching aspects about 73 students, medical and nursery, and 400 postgraduate for teaching and training. Next, please. In that way, learning requires restructuring, not just accumulating, because I think with we think the teaching must be based on scientific evidence and targeted in acquisition of professional competences, knowledge, skills, and attitudes. Next, please. The competency continuous expansion in the entire medical career is in 3 phases. 1, in undergraduate foundation, 2, postgraduate, and 3, in continuous mastery. In the first phase, focusing in theoretical basis, patient selection criteria, and active observation in the care circuit. Postgraduate is in relation to specialty, anesthesiology, surgery, specialties, etc. And the third phase in continuous mastery, lifelong and along all the career. Next, please. Safety begins in stringent patient selection criteria. All patients may be candidates for day surgery, but we have 4 filters: pathology mesh, clinical baseline, social support, and geographic proximity that concludes the candidate for day surgery. Next, please. The competence in care circuit may be in 5 steps. First steps in preparation of the patient. In step 2, the proper surgery to do. Adaptation in reanimation and pre-discharge. The own discharge to home, and the next call on permanent for the security of the patients. Next, please. In undergraduate rotations require active participations in reception, control evolution of the procedure, single act consults, surgical assistance, postoperative follow-up, and scientific activities in relation with all the procedure. All this may be reflected in the practice logbook. Next, please. So that reorganizing residents to match the paradigm may be this model, from traditional model to ambulatory model. In first case, managing extended hospital stays. 4, a rapid postoperative recovery and discharge criteria. Hospital-centered treatment decisions. 2, interactivity and work evaluation patients evolution at home, and bed management from the cost-benefits criteria and listing surgical stays safely. Next, please. The comprehensive competence metrics for graduate evaluation may be in 3 dimensions: knowledge, skills, and attitudes, and another way, an essential, important, evaluable. For example, in knowledge, care circuits, quality criteria, complications and treatment. Skills, basic diagnostics test, intra-unit communication, and the portfolio of surgical or anesthetic procedures in that center. And attitudes, all the times, patient-based, orientation, continuous improvement. And important and evaluable may be another questions. Next, please. New technical proficiencies define the modern surgical leader. The mind, the compass, the mind, the knowledge, quality methodology, evidence-based medicine, and care planning. The compass as attitude, patient communication, teamwork, responsibility taking. Next. These essential clinical skills for ambulatory safety may be in the area of the treatment: head, neck, surgical state sites, systemic management, and postoperative recovery. All maybe under support of the professionals, nursery and surgical anesthesiologist professionals. Next, please. In the case of surgery, maybe this ladder to get complexity, the progressive procedures target on surgical residence. For the example, the 1 degree for excision of skin lesions of biopsies, degree 2 in hernia, pleural, inguinal, and another little hernia, and degree 3 maybe about breast surgery, beginning benign and malignant tumors, and the advanced degree 4 maybe of laparoscopic and endocrine procedures. The number of the procedures in soft tissues in degree 1 maybe more than 20. In degree 2, about hernia for open or laparoscopic procedures, for total, at last 10 maybe by laparoscopic. Breast surgery, malignant and benign, about the same number, 15, and degree advances laparoscopy and endocrine, more than 30 cholecystectomy, and 10 on 5 thyroid and parathyroid procedures. Next, please. Educations must transition from dictators to facilitators in this new form to view the procedures. First, observe the practice. 2, highlights strengths. 3, suggest improvements. 4, establish action plans. And this is maybe the feedback loop for formative evaluation, as a new requires interactive for not doctrinal teaching. Next, please. So that the surgery unit may be a hub for continuous ecosystem training, because these developing safety and quality updates, primary care integration, and technological innovation, and maybe the unit as a reference in the surgery. Next, please. So that to take home the strategic imperatives for institutional implementation, maybe these 5 points. Mandate undergraduate exposure with active logbook, training across to the entire surgical circuit. Implement to 2 or 3 months dedicated rotations in anesthesia or surgical specialties. In our case, we have 5 months in the second year of the specialty, only dedicated to day surgery for more 20 years. Train surgeons, informative feedbacks, and facilitation over traditional doctrinal teaching. Track objectives, competence metrics across the knowledge, skills, and attitudes, rather than just time served. Integrated day surgery units constitutively with primary care to ensure safe out of hospital patient evolution. Next, please. This is the reference of this study. Next, please. Thank you. Thank you very much.
Thank you very much, Fernando, for your thoughts on teaching and training there. I think day surgery has always been and still remains today a fantastic environment for training for both the anaesthetic and surgical trainees and the wider day surgery team. You're dealing with patients that are generally quite predictable physiology. They've been pre-assessed for surgery. The surgical operations are often relatively short and repeatable, and you can get a high throughput done in a short space of time. So it remains an excellent environment for training our future doctors. Thank you very much. I wonder whether we've got any questions from our participants today.
Oh, excellent. This there is something on the Q&A. Let me check if there is. Ian, you want me to play this video?
No, I just wanted to share it. It's a really good human factors video. It covers the sad case of a lady who died in a hospital in England back in the early 2000s, and her husband has been campaigning on human factors and improving how we manage crises. And it was an airway crisis that this lady had, failed intubation, and she died. And people knew in the room what needed to happen, but the anaesthetist and everyone involved just got concentrated on the airway and didn't take help from outside. So it's well worth watching. I used to make all my trainees watch it in their first year. So I just thought I'd share it with you all.
Okay, I'll put it in the IAAS GA group so that everyone can have a look at it at their own leisure. So there are no questions. I thank the moderators and a few of you who have taken time and come on this. This is bound to happen in the initial webinars before everyone comes to know about this, and we are. It's an indication that we need to work hard towards it. We still need to spread the good word around the world, and eventually it will happen. The best part is that I'm going to edit this presentation. Is being recorded, and the videos will be available on our YouTube channel permanently for anybody to see. So don't get disheartened, and I'm sorry about the technical glitch. The first two webinars were on a free app. Now I have started subscription. So from third onwards, we probably will not have, and still I will check with the presenters once and, call for their presentations and video recordings of the next webinar, which will be on the 18th of July. And I hope to see more people on that webinar. I'm quite happy, and I thank you from the bottom of my heart. This is an initiative that I started, and I would like to see it succeed for IAAS.
Thank you very much, Naresh.
Thank you.
Thank you. And from my part of the world, it's already past 8:30 in the evening. It's time for a drink, and I wish you all a very good night, and we'll meet again.
Salute.
Again.
Cheers.
Bye.
Bye-bye.
Thank you.
Thank you, Naresh.
Bye.
Thank you. Bye-bye.
Bye-bye. Bye-bye.
Bye.
Bye-bye.